Hey everyone, and welcome to this explainer. I am so thrilled you're here today because we're jumping straight into what is arguably one of the most intense multi-drug protocols in all of pharmacology. We're talking about the heavy-hitting regimens used to treat TB, tuberculosis, and MAC, the Mycobacterium avium complex. Look, if you've ever stared at a TB treatment plan and just felt, well, totally overwhelmed by the sheer number of overlapping meds and wild side effects, you are in the exact right place. We're going to break the whole thing down step by step and make it make sense.
So before we get into the actual drugs, we kind of have to understand the enemy we're dealing with, right? Mycobacteria, they are not your average run-of-the-mill bacteria. They are incredibly stubborn adversaries. They wrap themselves in these ridiculously thick, waxy cell walls that are heavily fortified with a substance called mycolic acid. Your standard everyday antibiotics, they basically just bounce right off. So we need highly specific weapons, our antimycobacterials, that are custom designed to penetrate and completely disrupt that unique waxy armor.
All right, here's our roadmap for today. We'll start with the tuberculosis challenge, then move to isoniazid, the core weapon. Next up is rifampin, the orange alert, followed by pyrazinamide and ethambutol. Then we'll cover streptomycin, the injectable backup, and finally wrap things up with winning the TB war.
Okay, part 1, the tuberculosis challenge. Let's establish exactly why TB requires such a massive, prolonged pharmacological siege in the first place.
6 to 9. That is absolutely the most crucial number to keep in mind here. 6 to 9 months is the minimum duration for a standard TB treatment regimen. It's an incredibly long time, but you see, mycobacteria grow very slowly, and they can actually hide out dormantly inside the body. A quick 2-week burst of antibiotics isn't even going to scratch the surface. Plus, TB is notoriously good at mutating. If we just throw one drug at it for those 6 to 9 months, the bacteria will absolutely develop resistance. And that's exactly why we're forced to use a combination of multiple drugs simultaneously for that entire duration.
Moving on to part 2, isoniazid, the core weapon. This is the I in our ripe mnemonic, and it's really the heavy lifter.
Isoniazid, or INH as it's commonly known, is often the anchor of the whole regimen. Its mechanism of action is just brilliantly targeted. It actively inhibits the synthesis of mycolic acid. Remember that thick, waxy armor we were just talking about? Yeah. INH essentially stops the bacteria from ever building it. It dismantles those unique mycobacterial defenses from the ground up, leaving the bacteria completely exposed and vulnerable. It's a real game changer, used for active TB, latent TB infections, and even as a preventative prophylaxis.
But as you can probably guess, a weapon this powerful definitely comes with some serious collateral damage. We have to be on our toes with nursing interventions. First off, the liver takes a huge hit processing INH, so monitoring for hepatotoxicity via regular liver function tests, LFTs, is non-negotiable. Secondly, we have to constantly assess for peripheral neuropathy. Patients will describe it as this painful numbness or tingling in their hands and feet. Now here's the huge clinical takeaway. To prevent this neuropathy, which is actually caused by an INH-induced vitamin deficiency, we proactively give them vitamin B6, also known as pyridoxine. Honestly, you will almost never see INH administered without its trusty sidekick, vitamin B6.
All right, part 3, rifampin, the orange alert. We're at the R in ripe, dealing with a drug that has a side effect you are definitely not going to forget.
So, rifampin does its job by inhibiting RNA polymerase. But the thing you absolutely have to know, and more importantly, the thing your patient absolutely needs to know, is that it causes a completely harmless but totally shocking orange-red discoloration of their bodily fluids. We are literally talking about orange urine, orange sweat, and no joke, even orange tears. Imagine a patient who doesn't know this, right? They look in the mirror, they're crying orange tears, they would be absolutely terrified. Proactive client education here is just crucial. If you warn them ahead of time, it goes from being a terrifying medical emergency to just a weird, mild inconvenience.
Now, beyond the whole orange fluid situation, rifampin has a bit of a hidden danger. It's a massive inducer of the CYP450 enzyme system in the liver. What does that mean for us? Well, it dramatically speeds up the metabolism of a lot of other important drugs, basically wiping out their efficacy. For instance, it decreases the effectiveness of oral contraceptives, so patients are definitely going to need an alternate form of birth control. It also heavily interacts with the blood thinner warfarin, and it can seriously mess with antiretrovirals used for HIV. Trying to manage a patient's med list when they're taking rifampin, it's a really delicate, high-stakes balancing act.
Let's dive into part 4, pyrazinamide and ethambutol. This rounds out the P and E of our ripe regimen.
We rely on these too heavily, especially during those critical first 2 months of therapy, just to hit the bacteria from every possible angle. But let's contrast them, because their side effects are very distinct. Pyrazinamide, or PZA, disrupts the bacteria's membrane energetics. But the big catch? It carries a high risk of hyperuricemia. That's a buildup of uric acid, which can trigger incredibly painful gout flares in the joints. So, you've got to watch their uric acid levels and ask about joint pain. Now compare that to ethambutol, which inhibits arabinosalt transferase in the cell wall. Its signature risk is optic neuritis. This is a huge deal for a patient's visual acuity, and it can even cause color blindness. Because of this, anybody on ethambutol needs baseline and monthly vision and color testing. If they mention any vision changes at all, that is an immediate red flag.
Which brings us to part 5, streptomycin, the injectable backup. Sometimes the core regimen just isn't enough.
So what happens if the TB is resistant or if the case is just extremely severe? Well, that's when we call in the heavy artillery. Streptomycin sits outside the standard RIPE mnemonic today, though actually it used to be a primary treatment back in the day. It's a potent aminoglycoside, meaning it aggressively inhibits bacterial protein synthesis. But we keep it as a backup for a reason. The risks are severe. Aminoglycosides come with a huge risk of irreversible ototoxicity. We're talking profound hearing loss and balance issues. Plus, there's a high risk of nephrotoxicity, meaning serious kidney damage. The line between a therapeutic dose and a toxic dose is razor thin here, so strict peak and trough serum monitoring is absolutely mandatory to keep the patient safe. Finally, part 6, winning the TB war. Because having the right drugs is one thing, but actually getting a cure? That's a whole different story.
When you step back and look at the big picture, the clinical hurdles are pretty glaring. We've got INH causing neuropathy, rifampin turning fluids orange, PZA causing gout, ethambutol risking your eyesight, and streptomycin risking your hearing. It's a lot. But what's the most critical, universal pattern you need to remember here? Isoniazid, rifampin, and pyrazinamide all share a dangerous overlapping risk of hepatotoxicity. Essentially, the patient's liver is under an immense, coordinated attack from 3 different heavy-duty drugs all at the exact same time. Because of that overlapping toxicity and the incredibly long treatment duration, our management principles have to be super rigid. We are constantly monitoring those liver function tests. But you know what the single biggest challenge really is? Adherence. Think about it. Swallowing 4 different medications, probably feeling nauseous, sweating orange, and having to do it every single day for up to 9 months. It is miserable for the patient. But if they stop early, the bacteria mutate into multi-drug-resistant TB, MDR-TB, which is a massive global health crisis. So to prevent this, the absolute gold standard is directly observed therapy, or DOT. This literally means a healthcare worker physically stands there and watches the patient swallow their pills every single day. I know it sounds intense, maybe even a little extreme, but it's really the only proven way to guarantee adherence over that long haul.
So how does all this translate into a real-world practical workflow? Well, step 1, before we give a single pill, we get baseline liver function tests and a comprehensive eye exam for the ethambutol. Step 2, we initiate the massive 4-drug RIPE regimen. Step 3, we immediately co-administer vitamin B6 right alongside the INH to head off that neuropathy before it even starts. And finally, step 4, we lock in the cure by rigorously monitoring daily adherence through directly observed therapy. By taking all this complex pharmacology and organizing it into this logical step-by-step sequence, we give the patient the absolute best possible chance at a total cure.
Beating tuberculosis takes an incredible amount of coordination, resources, and most importantly, serious resilience from the patient. But looking at how tough this is really points us toward the future. With adherence to a 6 to 9 month regimen being so inherently difficult, how can modern healthcare systems innovate to combat the dangerous rise of multi-drug resistant TB? Can we develop faster-acting drugs? Or maybe long-acting injectables that bypass the need for a handful of daily pills? It is an ongoing, high-stakes battle between human pharmacology and bacterial resistance, and frankly, it's a war we absolutely cannot afford to lose. Thanks so much for joining me for this explainer. Keep learning, and I'll see you all next time.